first keynote speaker is Dr. Harvey Fineberg. Dr. Fineberg is the president of the Gordon and Betty Moore Foundation, a foundation dedicated to scientific discovery, environmental conservation, and preservation of the San Francisco Bay Area. Dr. Fineberg previously served as the president of the U.S. National Academy of Medicine, the former Institute of Medicine, the provost of Harvard University, and the dean of the Harvard T.H. Chan School of Public Health, where there has been a lot of alumni contacting me wanting to set up side parties for you with this conference. Dr. Fineberg earned his BA, MD, and PhD all from Harvard University. Dr. Fineberg's academic career focuses on health policy and medical decision-making, specializing in global health, medical technology assessment, vaccine evaluation, pandemic response, and the dissemination of medical innovations. He co-authored influential books such as Clinical Decision Analysis, Innovators in Physician Education, and The Epidemic That Never Was, about the 1976 swine flu immunization. He has co-edited works on AIDS prevention, vaccine safety, societal risk, and global health, and published extensively in professional journals. Dr. Fineberg has received multiple honorary degrees, the Frank Calderon Prize in Public Health, the Henry Friesen International Prize in Health Research. He serves on the editorial board of the New England Journal of Medicine, chairs the boards of the Scientific Philanthropy Alliance, the China Medical Board, upcoming chair, and the Peterson China on Healthcare Advisory Board, and the U.S. National Academy's Committee on Emerging Infectious Disease. Previously, he chaired the Carnegie Endowment for International Peace and the Hewlett Foundation, and co-founded the Society for Medical Decision Making. Please give a very warm welcome to Dr. Fineberg.
Good morning. Jason, thank you so much for your very kind introduction. Andrew, it's always a pleasure to be with you. Thank you so much for organizing this extraordinary gathering, and thank you for your many years of leadership and vision for medicine and medical education. You've always been a model for all of us. I'm very grateful to all of our colleagues who have come to participate. I really look forward very much to learning from each of you. And for me, it's a special pleasure to be here again in Taipei. I have, thinking back to my early visits, but it's 40 years ago, and as you see, there are many more formers than currents in my list of appointments, and so it has been quite a long time. But what has been most remarkable, coming only on occasion, it's like a slow motion flower unfolding here in Taiwan. How much has blossomed and how beautiful many things have become. I know those of you who are here also see many shortcomings and many challenges and many needs. But for those of us from the outside, I can say we are much more impressed with your achievements and the progress. And I thank you, and I'm very glad to have this chance to be with you. I just also want to say a word to thank Patrick Ng. I know he doesn't expect or want acknowledgement, but I am sure my colleagues have the same experience as I. Patrick's caring, continuous, and very valuable help in preparing every aspect of our journey and participation in the meeting. In this remarks this morning, I'm going to provide an overview of selective aspects of medical education reform. Any presentation that will be less than 3 months in duration much necessarily be highly selective. And so I hope that those themes and important topics that I've omitted may also emerge in the course of our deliberation over the coming 2 days. In my remarks, I want to cover 4 basic ideas. First, medical education is in need of perpetual reform. And I want to emphasize the word perpetual, because this is not a subject that you attend to once, complete it, and go on to the next subject. For reasons that I will describe, medical education is a subject that is in continuous need for attention and reform. Secondly, I just want to emphasize a point that Professor Wang already alluded to, that we have a persistent maldistribution of not only physicians, but nurses and other health professionals around the globe and locally. And I think it's a very critical feature for all of us to apprehend and understand as we think about the role of health professional training in the provision of needed services to the entire population. Third, I will describe a number of key trends in medical education, aspects of attention and reform. And finally, I'll return to a theme that Professor Wang introduced, the notion of education for life as a multi-pronged aspect of thinking about the role and future of medical education. Why is there perpetual need for reform? First, does any of us believe that our current system of medical education is ideal, is optimized to the current need? And even if we did, would we not recognize that there are many others with other variations in the duration, the content, the emphases, the timing, all aspects of the educational experience from whom we could learn and improve? But most importantly, the reason for the need for perpetual attention to reform is that the circumstances in which medical education prepares physicians and other health professionals is not static. It's dynamic along many dimensions. And those changes, even if you thought that what you had today was ideal, even if you thought you had already selected from every other experience what was optimally fit to the circumstances of today, because the environment is so rapidly changing, that solution would no longer be suited to the future. So let's come down to these drivers for reform. First, of course, are scientific discoveries and new ways of intervening at the preventive, diagnostic, therapeutic, overall management, and systems level. New knowledge that produces new insights, new treatments, new ways of detecting disease, new ways of monitoring the progress of disease, new ways of intervening to interdict disease and to prevent it, and to manage the needs of patients throughout the course of illness. This means that we have to continually update, revise, and make relevant the content of medical education. Let me go back. So this is just a list of some of the illustrations from recent years of some of the discoveries that are impacting and will impact the way in which medicine is conducted. The concept of personalized medicine, from genomic risk assessment to targeted treatments, CRISPR editing, STEM therapies, checkpoint inhibitors for cancer treatment, mRNA vaccines, rapid point-of-care diagnostics, new techniques to detect and determine the shape of proteins. All of these are currently and in the very near future going to impact the way in which the content and practice of medicine has to proceed, and therefore medical education be cognizant of. Secondly, another driver is the persistent maldistribution of healthcare resources. We have not solved this problem as long as any of us in this room have been attending to health and medical education. This is an example that it's not about just producing more. From the decade of 2008 to 2018, the world produced twice as many doctors and about 2.5 times the number of nurses. And the numbers in practice also increased. However, when you examine the distributions globally or locally, in the world at large, the number of doctors per 10,000 population by countries is literally 2 orders of magnitude, less than 1 to almost 100. And within a wealthy country like the United States, if you look at the distribution by county, you find a distribution that ranges from about 2 to about more than 50. So this problem of maldistribution, which we could elaborate on in terms of specialties, in terms of the needs of primary care, in terms of the needs of patients at different stages of life, all of these are persistent challenges, not to any one medical education activity, but to the whole of our medical education enterprise and the way it meets the needs of the health of the population. A third driver are the combination of changes in the expression and nature and intensity of illness, because in part the population is changing, and in part because of changes in environmental conditions such as climate disruption, and in part because of other drivers of emerging infection, as an example. So, for example, look at the population distributions of Angola and Japan a decade ago. Basically, the classic distribution, wide bottom at the early ages and then narrowing up at the top, represented still at that time in Angola. But look at Japan. Japan is squared in its population distribution. Japan will be among the first countries to experience the increasing burden of aging population relative to total population. But it's not just Japan. This is China, and China is not very far behind. And this, of course, is partly a function of the one-child policy, but it's also a reflection of success. It's a reflection of success of survival to the later stages of life. But these transitions, the epidemiologic transition of aging, the demographic inversion of squaring of the population to a much higher proportion of elders, and the emergence of new conditions, all dictate novel, disruptive, transformative change in the way we educate future physicians. We've alluded to high cost of education. Now, this is very socially dependent in different countries. It depends entirely on the ways in which healthcare is financed. But in the United States, a high cost of what we regard as 4 years of undergraduate medical education. As you know, in the US system, that typically follows 4 years of college education. The 4 years of medical education in the US are leading many to ask, can we reduce the time to 3 years? Can we intensify the training? The cost today in the US, the average per year is US $59,000. The average student today graduating from medicine in the United States has a debt of over 200,000 US. And to exacerbate these problems, we've now are encountering very recent cutbacks and undermining of the financial base for medical schools in the US. And that is hopefully a short-term problem, but still it's a very real threat to education for medicine, at least throughout the US. And finally, I just want to point to the appreciation of social determinants, the global interdependencies in health, the movement of peoples, migration. All of these factors, again, influence the way in which we need to take account as we reform education. And all of this is on top of new educational technologies. The ways to educate, whatever the content, whatever the needs, the ways we have to take advantage of training the next generation of clinicians, researchers, and leaders in medicine. And we'll be talking more about that in a few minutes, but also hearing much more about this in the course of our 2 days together. I want to just very briefly touch upon 4 key trends in medical education. The first is competency-based education. This is a theme that has grown up in a number of countries. It has been increasingly incorporated in the thinking about what the object and measure of successful education should be. And in thinking about the content of medical education, it may be useful to think of 3 layers, one layer of which is the informative content. What's the knowledge base that one needs in order to be a successful physician? The second is the formative. What are the attitudes and values that you need to practice the kind of humanistic, patient-centered, and patient-dedicated care that we want from our physicians? How do you internalize what it means to be a health professional and the ethical and social responsibility that comes with becoming a member of that profession? And then the transformative level is the higher level of skills in which we look for leadership, vision, capacity to innovate, ways of understanding not just the individual patient in front of you, but the context of care in meeting needs of the larger society, in understanding the importance of simultaneously caring for that patient and ensuring that all patients can get the care that they need, and having the skills as well as the will to effect that kind of change. And those can relate to 3 layers of competencies that are critically a part of medical education. The foundational competencies, which are really about the things you need to master in order to be a successful physician and clinician. The specialized, more detailed depth of knowledge of the competencies that are required to practice in depth in any of the subspecialties, but also the integrative competencies that inform the sort of leadership transformative elements that I spoke before, but also our higher level integration of the ethics of practice, of critical reading and analysis, of leadership, of mobilizing others, of being part of successful teams and being a successful leader of teams, of acting in ways that elevate the practice of medicine, the experience of patients, and health of a whole community. Now, just to illustrate some of the ways this translates into teaching requirements in medicine, a very useful theme that has come to be more and more popular in the last decade are entrustable professional activities as requirements for education. In the US, the American Association of Medical Colleges articulated 13 core competencies, the so-called entrustable professional activities, meaning that you expect the graduating medical student as they enter their internship or residency to have mastered these basic skills of interpreting the needs of the patient, of deciding on the course of care, and so forth. New frameworks of professional activities and markers. This particularly in some of our specialty organizations. The American Board of Internal Medicine, among others, has been very active, along with other subspecialties, in introducing the idea of continuing education and recertification over time. And then competency-based education across all of professional disciplines. This extends through medicine, but also out to other health professional training in nursing and in pharmacy and in related caregiving responsibilities. So competency-based education is a very critical part. There are many challenges, though, to doing it well and doing it successfully. First is making sure that as educators, we've established the relevant competency-based curriculum. What is it that actually instills and reinforces, manages, and certifies to everyone's satisfaction that the competency has indeed been mastered? We need reliable assessments, ways that consistently look at the ability of the student and future physician to achieve and express these competencies. There are a whole spectrum of generic or more general medical competencies and more specialized. What is the right balance for what type of training, in what context, at what stage of training, and how do we then convert that into the relevant curriculum? A very big unanswered question is, what is the measurable impact of all of this on patient outcomes? And this is a big challenge for those of us concerned also about research on education as well as research to advance medicine. And finally, most of the competencies really relate to the informative part of medical training that I spoke of. The formative competencies and the transformative competencies are much more elusive and difficult to nail down, and one could argue even more important to the elevated success of the medical profession and of the individual clinician. The second theme I want to just mention briefly is interprofessional education. The basic idea here is, can we introduce and utilize training experience across the professions that actually matches the multi-professional teams that care for patients? If you are a cancer patient, you're not only cared for by your physician, you have a whole team that is responsible in a day in and day out operation of care. And that applies to the most specialized intervention all the way to the most fundamental primary care. And yet, our educational systems are much more siloed continually than our practice systems. And there have been some very important innovations and efforts to overcome this in joint training, and we have a lot more to learn from those experiments. This also relates to the question of joint competencies, and I want to come to this a little bit later about the dual professional opportunities for physicians moving into the future. And finally, it's not only about the clinical to clinician partnerships and intervention. Increasingly, for example, data scientists, computing science, engineering, aspects of ethics, public health, these skill sets and professions are increasingly valuable partners in the successful clinician's ability to take care of patients. So interprofessional collaboration across the clinical and non-clinical relevant professions is a really very nascent aspect of interprofessional education. Third, I want to allude to technology-facilitated education because this is both so exciting, so fundamental, and potentially transformative for the practice of medicine as it is for so many other aspects of our work and our lives and our way of living. But there are some specific elements that I want to emphasize. First, we should understand that new technology that applies to health affects both the content of education. What does the clinician now need to know enough about to be successful that were not necessarily relevant 10 years ago? And also, it directly impacts the tools we can use for education itself. So it's both the content of education and the method of education that is influenced by the new technologies. And it's worth noting that the 4.5 years of the principal impact of the COVID pandemic definitely accelerated the adoption and deployment of some aspects of these technologies, and in particular telemedicine as a way of reaching patients, and the virtual classroom as a way of continuing education when it was not prudent to be gathered in one room. All of those changes were definitely accelerated by the COVID experience. Some of the examples that are relevant today for us as educators also, computer-facilitated synchronous and asynchronous learning. I don't know how many of you are lecturers in medicine, but how many students actually show up in the lecture today versus are willing and able to look at the lecture on their own time? This is a change in the way students are learning, and it's almost a beginning of what some are taking to the next step of what's called the flipped classroom, where the content of a lecture is expected for the student to be studied and learned on their own. But what you do together is solve problems based on that material and novel introduction. And that, in a way, putting the homework in the classroom and the class lecture to be done at home is the flipped classroom. Data, big data today is so important for the practice of medicine, vital to so many studies, and it's a very important tool to help and support education itself. And finally, geography has been much reduced in the form of a barrier to successful education. The video podcasts, so-called vodcasts, the continued podcasts, the micro videos, the large classroom, the global reach, all of these have transformed the accessibility of medical education in different settings to different individuals at different stages. And it's all part of the array of technologies that are novel tools for medical educators. This is just a continued list of virtual patients and avatars, robots and simulation. I don't know, in Taiwan, are you still doing dissections of cadavers at medical training? Yes? Many medical schools in the US no longer are doing it. It's all done virtually. Augmented reality is coming increasingly to the fore as part of medical education, and we'll be talking a lot at this meeting about artificial intelligence, its impact on medicine and medical practice, but I don't think we have fully appreciated the way in which AI is also going to impact learning and our ability to master material, and even what material it is most important to have mastered at what stages. And so that is also going to be a very important trend coming in the next decade. Finally, I do want to mention this idea of dual professional training. That is, the physician who is professionally also something else, not merely an amateur, player, but the physician who's also embedded as a scientist. This is not a new idea. This has been a kind of standard opportunity for the last 80 years. But many other careers for physicians are now embedded in these kinds of dualities. The physician educator, the physician manager, the physician policy analyst, the physician public health professional, the physician ethicist, we might add the physician engineer, and many more that are becoming not simply the occasional exception to the career path, but a genuine choice and opportunity for medical professionals to contribute in new and more exciting and more comprehensive and more transformative ways. Now finally, I want to come back to a theme that Andrew introduced, which is the idea of education for life, and to re-emphasize these three dimensions of what we mean by education for life. First and fundamentally, lifelong professional education. All of those same forces that drive the need for reform in medical education of new physicians also drive the need for continuous learning in the existing workforce of physicians. But secondly, thinking about life and education for life is also about the life of our patients and their families, the needs that must be met at every stage of life from birth to the end of life. And adding to that, the population distribution change in which the relative needs at different stages of life are going to be more and more prominent, especially as the population continues with the epidemiologic transition to a concentration of aging, chronic disease, and the needs of aging ability. And finally, I want to emphasize that as educators, and this again was something that really came forward in the COVID pandemic, meeting the needs of our trainees and physicians for their lives is a very fundamental and important element of education for life. It's education for living your life and being a successful professional and a successful parent and a successful member of society and a successful leader. All of these things integrated in a way that help each clinician, physician, and medical leader understand for themselves how they can achieve that balance, what is useful to them, and knowing that they are not the only one undergoing the strain, the stress, the demand that a life as a medical professional entails. So, in conclusion, I just want to emphasize a few points. First, any of us concerned with educational reform for medicine or public health or nursing or any of the health professions, that is what I call an evergreen exercise. It never goes out of fashion. The leaves never fall from the tree. You always have to attend and trim and add and revise. This is going to be a continuous challenge for the next generation and the generation after that. The fundamental need is to align what we teach and how we teach with the dynamic situation of change in science, in health and healthcare, and in society, in meeting the social needs. There's a famous saying from the Canadian hockey player Wayne Gretzky when he was asked, "What is the secret of your success?" He said, "I skate to where the puck is going to be, not to where it is." And in medicine, we have to prepare our future physicians for what medicine will demand of them not the way it is, but what it will be. And finally, I would emphasize that the most fundamental competency we can convey, that we can master, that we can adopt, that we can strive to attain throughout our lives is the idea of our ability to be a continuous learner, to continue to attend to the developments in science and technology, to continue to apprehend the evolution and changes in society's needs for health, and continue to absorb and be engaged as part of the solution to meet the ongoing health needs. Finally, I think Andrew gave us a very important mandate for this meeting, transformation of medical education that combines the most sophisticated technologic and scientific advance with the most fundamental humanistic appreciation of the needs of the individual patient, regarding everyone with the dignity and respect that they deserve. And although we may think that these are on some kind of a continuum that extends from the softest side of humanistic medicine to the hardest edge of technology and science, I would like to reinforce Andrew's point to say we can bring those two ends together. We can create the two-sided physician who is both the master of the latest of science and technology and yet continually grounded in meeting the needs of patients, families, and communities. Thank you all very much.
If you could stay there, we have a few minutes for questions. Thank you for giving us the, or challenging us for the need for continuous medical education reform and providing such an excellent framework for doing that. We have a few minutes for questions. If people from the audience have questions, please raise your hand.
Thank you. Professor Fineberg, I'm Xin von Bergman from Canada, UBC. So first of all, thank you for that presentation. It's very stimulus and very transformative. As you have said, one of the questions that in listening to you emerged from this is, where do you see professional identity formation in the school of your medical school? So in many ways, when you talk about the formative, and transformative, in many ways we argued in our research is the professional identity formations can actually sit at the transformative. When I looked it up in the medical schools, very few medical schools has tried to march on this particular journey. So I'm curious about your thoughts on this.
Well, thank you very much for the comment and question. You know, I always hesitate to do a blanket characterization of medical education, because when one really probes, very often someone is doing something along the lines of what you thought needed to be done. And I would say our first job is to have more opportunity to learn from one another about how we are approaching the education experience of our students. It is very easy to think the way we have done it is a comfortable way, a good way, we're very satisfied, and I prefer a restless dissatisfaction. I believe that even though universities and medical schools are not famous for rapid innovation, at least we need to be prepared for periodic disruptive innovation. Now, when it comes to the specific relation of the teaching of some of the competencies, especially at the transformative level, there are some very interesting experiments about this, and particularly if one understands that one of the competencies are critical thinking and critical interpretation. There, in many medical schools, we have some effort to instill in the students a much more, let us say, skeptical and critical eye about what really constitutes legitimate evidence. So I think my main answer is let's learn from one another, because I think what you have said is a very important challenge for us, and I think that we can benefit by making sure we are taking advantage of everyone's experience, not only our own.
Please.
Professor Fineberg, enjoy your talk very much. Just zone from Singapore. I've been teaching medical students for about 35 years, and during COVID time, it was a great challenge because we cannot go to the wards to see patients, and I teach them clinical skills just by showing cases and pictures, and there were some 30 students in my group. I remember I asked questions. There was this girl, very smart, and she answered all my questions on Zoom. And I asked her, oh, Susan, you look very smart. Can you turn on your camera so that I can know who you are? And she said, I'm sorry, Professor, I'm still in bed. And she was sleeping. Now, this is not a joke, but I just want to put it to you that there is such a challenge of teaching human relationship, bedside manner, a lot of things that we hold values on. By using telemedicine and new technology, without the real human touch, without laying our hands on patient's abdomen and putting a stethoscope on the chest and talking to the patient, how would you compromise, using technology, virtual reality, and so on in our teaching versus really bringing patients or bringing our students to the patient for the teaching?
Thank you for the story of your experience and for the good question. First, I would like the name of this student in case I am ever in Singapore and need a doctor, so I will be able to call her. All of the formative competencies, not the informative, the formative competencies of relating to the patient, of becoming a clinician, mostly, I feel traditionally, we have learned these by observation, by kind of emulation, you might say osmosis, you're in the environment and you're supposed to absorb it. And I think one of the big challenges is how do we take and distill some of that necessary experiential learning and also codify it in some lessons or reminders. One small example from my own experience that I remember to this day so vividly. I was a student, either a third or fourth year student, and we were making rounds, and the chief of the service was leading these rounds of hospital patients, and the chief resident was concerned because of time, but the chief, at every patient, pulled a chair up to the bed and sat down with eye level to the level of the patient and spoke directly to the patient and connected and touched the patient. And he never said anything that this is how you deal with the patient. But my observing that stayed with me to this day, and certainly was something I learned. Can we extract these lessons and not simply over Zoom, but the lessons you have to learn at the bedside, reinforce them, but also try to distill some of the key ones that we can also convey in a more direct way to our students. So that would be, for me, how I would try to augment the bedside learning experience with an effort to be a little more direct and explicit. Because for some of us, other lessons escaped us, and maybe a reminder would say, oh yes, now I do remember that. So that would be my hope that we can accomplish.
Yeah, Professor. Yeah.
I'm inspired very much from Taiwan National Yangming University, and actually we have different track for selecting students from high school. And you have mentioned duality, and we have 3 tracks. One is physician, and one is physician scientist, and one is a physician engineer. And I'm curious about the differentiated stage for the students, just like stem cell. We select the student at the beginning, but I'm curious what's the most adequate time for divide them to different tracks? Is at the beginning or at the end or at the midtime?
Yeah.
Thank you.
You know, this is such an important challenge of design. And of course, you know, in any society, any country, medical education fits within the larger structure of education and how the educational function is designed, and the opportunity to make adjustments is limited in that way. But I would say, in relation to different tracks, at what level of specialization, I would try to think first about what are the common elements of knowledge and mastery of skills that apply regardless of which track. And is there a set of these? Secondly, I would try to think of both knowledge and skills. The beauty to me of the competency-based concept is it recognizes that clinicians need not only to have it in their head, they have to have it in their hands. They have to be able to do the right things, not just know the right answers. And those are not always the same. So the second is, with each track, I would try to think both about what they need to know at each stage and what they need to be able to do at each stage. And then finally, I don't know how much opportunity there is for learning across the specialty layers after one has begun to really specialize, because there could be a further layer of mutual learning as one understands more how each of the tracks contributes to health and how to most effectively work with your counterpart professionals who have other specialties. So those are things I would think about in this. And please understand that it's coming from someone who's not really versed in the experience that you have for your students, but these are things I would think about. Common learning, ability to do as well as to know, and cross-specialty learning at a later stage. Thank you.
And many thanks to Professor Fineberg. Very inspiring talk. I'm just wondering about maybe in your experience, maybe have some background, ethnic background or regional background differences, like in Oriental countries, in Taiwan, Japan, Korea. And I think that our education since childhood usually more passive than in the United States. So to talk about the lifelong learning, for example, the flipped classroom in Taiwan, that many students, we think that will be a burden for them. So the faculty, if we want to do this, I think we have a big barrier there. And how to evaluate the lifelong learning, the progress of the students, the skills for lifelong learning. So in your experience to compare the two different cultural contexts, And what do you have any comments about this point? Thank you.
Well, thank you. Thank you very much for the question. For in any medical education system, there are some very fundamental elements that we didn't even begin to talk about. You need the space for proper education. You need access to the right clinician experts and basic science experts to do the teaching. You need to have the relation with the clinical settings to augment that learning. And so these are elements of the nuts and bolts of training that a modern medical training system has to ensure. And so these are all, in a way, prior to anything I was talking about, that are necessities for proper medical education. When it comes to lifelong learning, of course, the school dedicated to 4 years cannot be responsible for a lifetime of learning. But I think one can select students who have the curiosity and the drive and the desire to be always current. Second, one can give them tools for the kind of critical learning and access and technology-assisted learning today that can enable them to achieve that lifelong learning. And third, there can be the system, not so much the schools, more the certifying and accrediting bodies, which periodically require that the continuing practice is matched by demonstrated ability to be recertified in the layer and level of your practice. And I think if you have a system that selects the right student, gives them the right skills and motivation and tools, and has a layering of expectation and sometimes requirement, I think then you have the ingredients for lifelong learning.
Professor Fineberg, thank you so much. I learned a lot. I'm Dr. Cao Ronghu from Taipei Medical Education. My question is about interprofessional education. I found it's easy to conduct the interprofessional education in the medical team, but I think it's not easy to align the value or thought with the outside the medical team, business or management, but it's become more and more important. My question is that, do you think how to integrate this part into our education? Should we invite the professor from business to our medical school, or we should build our own business curriculum? Thank you.
It's very easy to say, I said it myself very glibly, interprofessional education. It's very hard to actually do it well. So I don't diminish at all the challenge of doing it. And it's always fascinated me, not just my own experience, my observation of my own colleagues and then generations of students, the transformation in their minds of when they become a doctor or a surgeon or a pediatrician. And it's about learning and absorbing in a way the ethos and culture and values of that group that you aspire to be part of. It's not even taught directly, but there's a point that you absorb it. How do we acknowledge and celebrate that professional identity with the growing necessity of appreciating, working with, understanding, and using the sister professions around you? Personally, I think one of the most effective ways to accomplish this is not to bring a professor from another faculty to teach your students, but rather to use cases that require both sets of skills and have elective courses at least where the students from each of the different professions can come together in the same classroom. And ideally, maybe jointly taught. But the key is that they learn from the cases that illustrate why they're together. That the cases themselves show that it was essential that you had the engineer, the data expert, the public health professional at that moment, working along with the nurses, the pharmacist, and the physician, etc. So I would try to do it more around experience of case-based learning of the students working together, because that would actually also model for them what they then need to do as team-based co-workers in care of patients. Thank you. Yes?
I share my limited experience here in Taiwan.
I think you just have to hold it closer.
When we started in 1990, we were very small. I only recruited maybe 10 people, 10 attending physicians. And every afternoon at 3, we would make rounds together. And some are more senior and others are more junior. And we have pathologists rounding. Have you seen an anatomic pathologist rounding with clinicians? And we have surgeons. We have radiation people, radiology people. And we make rounds together from 3 till 7, 4 hours each day, Monday through Friday. That made a difference. And so the pathologist is not working behind the microscope. The pathologist is at the bedside. And so this is the way we learn pathology, and all the variations of interpretation that he knew was transferred to us. And now we are about 140 staff, which is still very small. But I think some of them are here actually. We have an infectious disease person, we have a reconstructive surgeon here, and they talk to each other. So even though I don't think the infectious disease man could operate, but somehow he appreciates the findings of good reconstructive surgery, especially for head and neck cancer. And the care has been taken not to get into trouble with infection, especially methicillin-resistant staph infection, which is quite common here in Thailand. So ours is extremely low, probably in the teens, while Duke I know is higher. I'm sure you probably are very critical about it. And so the way I learned is at Duke I was trying to put people together with some difficulty. But in Taiwan, partly because we are small and partly because we wanted to offer the best care for the patients, not just by taking out something or irradiating something and giving chemotherapy to the patient, but together in a fine combination. And that's the way we learn.
It's a marvelous example, Andrew, and I think it illustrates another point. If you start in the right way, it's much easier than if you have to fix something that has been broken for a long time. And this is a good lesson for all of us, I think, as we imagine ways to improve care. Thank you. Do we have time for one more?
Ted Fineberg, I truly enjoy your talk. My name is Yuan Lai. I work in Andrews Foundation. By listening to your talk, I can't help but ask you one question. I'm a neurologist. I like bedside teaching very well. I found out it's easier to teach students how to do reflex, but very hard to teach them how to reflect. Because I found out the longer years you work in clinical science, the better your skill is. And then you tend to be seeing patient by reflex. But if you really don't have a good physician who can do good reflex as well as reflect, I truly like to know when you're doing bedside teaching, can you just pick up one of the examples that you use that occasion to teach students reflect? Because I thought a good physician is not only who can do reflex as a neurologist, but you really need to train them based on the history of the patient and the signs you detected at the bedside, and you use that opportunity in kind of induce them or lead them into some sort of reflective mood to tell us what they thought about this case. And I think if we can train the students while in the transformative stage of form of influence, we can train them to not only look at the reflex, by their reflex, but they have to think about reflective, the importance. Can you share one example you did?
I am sure you can do much better than I could do with a good example. You know, I always have loved neurology and neuroscience because history will tell you what is wrong and the careful exam tells you where it is wrong. And I think for neurologists especially, the critical time with the patient has always been the most satisfying, and I think for many, the reason they love being in that field. But how to teach at the bedside, to be with the patient, but also thinking. This is an art, and I don't have a magical answer for it. But I hope that maybe being in the presence of really experienced clinicians is one way that students can absorb these lessons. Thank you.
Thank you, Professor Fineberg, for your very wonderful talk. I am Chong Hao Chai from China Medical University College of Medicine in Taiwan. As just you mentioned, the maldistribution of professional is a big problem, I think, not only in our country, but also in the United States. I would like to know, do you have any comment on this issue from the medical education point of view?
Well, thank you. To come back to this question, we could have a whole conference and more on the maldistribution, because what we were talking about in the numbers is only at the surface. There's also by specialty. For primary care, it's even worse. And if you look at the array of basic, secondary, tertiary, quaternary access, you can see that it gets yet worse. And not only is it a serious problem, I've been admiring the problem for 4 decades. I've not solved the problem, and nor has any of us, because it's still a major challenge. I believe that it cannot be solved at one level only. That is to say, we do need policy change. For example, one program in the US that had some modest success was a program in which the trainee, if they signed up for service for 2 years, could have some of their debt relieved, and often found they liked practice where they were then practicing. And so it helped encourage people to continue in the underserved area. Policy, in other words, that provides advantages for career commitment could be one dimension of improving the distribution of service. Secondly, I think we have to recognize selecting for study as physicians and nurses people who want to return to their community to provide that service, because that's who they are as human beings and what they want to dedicate their career, their life. That should be a real consideration in their ability to get access to the training that they need. Experience, what we can do in medical training of giving people the opportunity for experiences in a positive way in underserved areas is maybe one other step that medical educators could themselves do. And finally, we know it's not simply a matter of numbers, but it is a matter of the right people with the right incentives, the policies and the training that can reinforce the choice to spend a career or a large portion in that service. And finally, our compensation system has to recognize the added value that a physician provides by serving in an underserved area. And right now, none of us do that very well. So those are some ways, apart from a kind of, I would call it radical conscription model. You know, you're a doctor, you're going to be sent there. You know, in a society that does not operate in this way, then I think these kinds of combinations of policies, incentives, training opportunities may be our best hope. Finally, I harbor a faint hope, but a real one, that many of the technologies that we're going to be discussing, digital health, telemedicine, artificial intelligence enhancements, can aid in the accessibility, distribution, and quality of service otherwise not available. So the one new, I would say, element compared to these other tools that is now a possibility is the way in which the proper deployment of technology could also enhance accessibility and quality. Thank you.
Thank you, Dr. Fineberg, for your very thoughtful responses. You just heard from 16 of medical schools here, and also from Singapore, Professor Song. And tomorrow we'll have a small session to discuss further, and for the training of management individuals. We have Dr. Kevin Shulman, who teaches both at Stanford Medical School and the Business School, so that's for tomorrow. And finally, I want to say that when you mentioned what we learned by observation, I remember Dr. Morton Swartz, who was my clerkship attending for co-clerkship at the Mass General. And I saw him putting on socks for patients after each visit. And that, I can never forget that picture. Let's thank Dr. Fineberg again for the presentation.